Thank you very much. I appreciate it very much.
Yes.
All right. Well, thank you and welcome. I'm so glad that all of you are here. And just to kind of start a little bit on a casual side, I just want to tell you a little story and then we'll get into the meat of this. I want to take you back to the summer of 1990. I was living in Jacksonville, Florida. I was not in medicine at the time. I was working for one of the major pharmaceutical companies. I had just gotten a big promotion and my career was really on fire. My personal life was a little mess. I was going through a divorce, but that's a different story. But I was working with one of my pulmonologists, and he let me shadow him for a day. And the very last patient of the day, we took into his private office instead of an exam room. We sat and talked to this patient for about 15 minutes, and over that course of time, I watched him tell this precious woman that she had lung cancer. And as you can imagine, every emotion that would go through your mind when getting such devastating news went through hers. I watched her life flash before her eyes. I also got to watch the amazing dance that happened between my friend and this precious woman, where she went from a place of complete terror to a place of hope. Now, her life changed forever that day, as you can imagine, but what I didn't expect is my life changed forever that day too. It was that day that I decided I wanted to go to medical school. There were a few problems though. I was 26 years old, and that's not a typical age to make a major shift in that direction. I had a business degree. I only had one chemistry class and I got a C in it. So I'm sure you can imagine the medical school directors were not knocking down my door begging me to come. However, I knew this was something I had to do, so I made a plan. I quit my job, I sold my house, I packed up my 2 dogs, and I moved to Gainesville. I became a waitress while I did all of the science classes, and 11 years later, I started my practice here in Panama City. So I tell you that story for a couple of reasons. Number one, sometimes things we are faced with in life are scary, but it's worth going after them. I probably peed myself a little bit then too, because it was a scary time. And I relate that to what we're going to talk about today, because sometimes people don't seek information or treatment about conditions that they have because they're afraid that the doctor's going to tell them they have to do something they don't want to do, or they have to have surgery that they don't want to have, or they have to take a medicine that they don't want. Information is never a bad thing. And nothing that we're going to talk about today is terminal. Nothing here kills anyone unless you trip over your dog and break a hip on your way to the bathroom. But it's all treatable. So I'm hoping today that some of you will learn at least one thing that can help make your life better, with or without the help of a professional. Okay? So what we're going to talk about today is, we're going to talk about 3 things. We're going to talk about 2 different types of incontinence, and then I want to talk about something that most people know nothing about, but is very, very common, and is something that is my passion to make known to people so that we can treat it. So first, let's define it. Urinary continence basically is urine escaping your bladder when you don't want it to, for whatever reason that happens. It is not a disease, it is a symptom. And there are lots of things that can cause urine to leak from the bladder. It is not a natural part of aging. A lot of people have it and it's common, but that doesn't mean you have to put up with it. It doesn't mean you can't seek treatment and make your life better. There are lots of things that we can do, but I will tell you that it starts out gradual and it is degenerative. So you might have mild leakage now, and next year it might be a little bit worse, but it is going to get worse over time. The most important thing I want everybody in here to walk away with today is to know that not all incontinence is the same. This is the biggest misperception I deal with in my office, is that people complain that they leak and they think that there's one fix for it. And the problem is there's different types of leakage, and I have to know what type of leakage you have in order to help give you the options that work for you. And not everybody has one type. Sometimes people come in with 2. So for example, the 2 most common are stress and urge incontinence, which are the 2 here. And that's what we're going to spend the bulk of our time talking about today. But some people come in with mixed incontinence, which basically means you have more than one reason you're leaking. And we have to address both, or all 3, if you're doing that in order to get you off the pads. Overflow incontinence, that's pretty common and unrecognized too. And basically that's people who don't empty their bladder very well. And it's like trying to walk across the room with a full glass of milk. You're going to spill some of it. So that's overflow incontinence. And then functional incontinence is something that we see a lot in nursing homes, where people are debilitated and don't physically have the time to get to the bathroom with the amount of warning that they have, or they're dependent on the nurses to come get them. So it's not really that they have one of the other ones, it's more of a situational thing that they're dealing with. Okay, so let's talk about stress incontinence first. The most important thing to understand about stress incontinence is that it always happens with activity. It's a physical external pressure on the bladder. So if I have a water balloon here and I squish it from the outside and I force water to come out the opening, that's stress incontinence. So it absolutely always will happen with some sort of movement. The most common things are cough, laugh, sneeze. It can be something as mild as standing up from a sitting position or walking across the room, but it will never happen while you're sitting perfectly still. It is the most common type of incontinence among women. It is very, very common. 15 million American women have stress urinary incontinence. These are some of the activities that we talked about, or that I just mentioned, but exercise is a real common one. You know, jumping jacks, jumping on a trampoline, cough, laugh, sneeze, throwing up, those kinds of things. Standing up from a chair can be it, but it's always with movement. These are the kinds of things that lead to it. About everything that we do as women. Pregnancy, which I think is probably the most hazardous thing that we do because it causes everything. But pregnancy, vaginal delivery, hysterectomy, gravity working on us over time, loss of collagen, loss of elastin. I mean, all of our other tissues are starting to sag a little bit. Well, so does everything in the pelvis, and that can lead to stress urinary incontinence. Poor nutrition, smoking leads to poor tissue. So as your tissue gets weaker, it becomes more prone to stress urinary incontinence. And one of the biggest factors actually is genetics. So if your mom leaked with cough, laugh, sneeze, you are more likely to leak with cough, laugh, sneeze. So this is physically what happens. It's a combination of a weak pelvic floor, the support system under the urethra and the bladder, combined with external physical pressure. We all have external pressure to the bladder as we live life. You know, when we're teenagers and we're cheerleaders and we're doing jumping jacks, nobody leaks in those situations. As we get older, we actually tend to do less, but we leak easier. And it's mostly because the tissue around the urethra and the bladder neck is weakened and it's looser, so it's more likely to bounce open, which I'm going to show you in just a second. So here's the anatomy. This is what I show my patients in the office. So I show the side picture here because the most important thing here is I want people to realize is that the vagina does not point to our heads, it points to our tailbones. So it's at an angle. The front wall of the urethra and the bladder are fixed to the pubic bone, so they're pretty solid. They're not going anywhere. The back wall of the urethra and the bladder are supported by the soft tissue, because we women in this room, we are designed to squeeze out bowling balls. Our bones are out here, and all of this is soft tissue so that we can deliver babies. Well, that soft tissue gets softer as we get older. So what happens is, I'll put this down for just a second. So if my wrist or my hand is the urethra, and my wrists are the bladder neck, what happens is you cough, laugh, sneeze. This wall stays put, the back wall gets pulled apart, urine squirts out. Okay, so that's what happens. Now, when I examine a woman in the office, I'm looking at it like this. You can see here the urethra is right here. Here's the under part of the urethra. The vagina is back here. So when I look, the most common thing that we see with stress incontinence is something called hypermobility of the urethra. It just means it moves. So what I see is it just bounces down. And that's the most common thing that we see. And it's because that tissue is not supported anymore. Sometimes women will leak while lying on their back with an empty bladder when I examine them. Sometimes they don't. Believe it or not, that really does give me very useful information because we never completely empty our bladders. So if I examine a woman and she coughs and she does not leak, that usually tells me that her leak point pressure is above 100 centimeters of water pressure. That is important because the higher your leak point pressure is, the easier it is to fix you. I kind of jokingly say if the house is falling down, a coat of paint isn't going to fix it, okay? But so the higher it is, the better. One of my attendings used to say that a Mack truck could run over your pelvis and you should not leak. Your bladder would rupture, but it shouldn't leak because the support around the urethra should be the same as it is around the bladder. Okay, so what are your options for stress incontinence? I always start with the simplest, easiest thing first and then work my way up and let people choose. The simplest thing to do is some Kegel exercises, which everybody has heard of. Most people probably don't do them correctly, believe it or not, but it's the most common thing to start with. And that is where you squeeze the muscle that you would normally use to cut off your urinary stream, or the muscle that you would use to make sure you don't pass gas. If you squeeze that, hold it for 5 to 10 seconds and then let it go, and do that systematically, you tighten the sphincter. Now that doesn't change the underlying problem that the tissue is bouncing, but where I showed you that side picture, it tightens the outer door. So for mild incontinence, Kegel exercises really can help. The next level of things would be doing more formalized pelvic floor rehab, kind of like physical therapy for the pelvis. So any of you who have either had a knee replaced or know someone who had a knee replaced, they might have gone through physical therapy afterwards to get them strong enough to be used to that joint, and then they were able to maintain it at home. That's what pelvic floor rehab is like. I kind of describe it as going to the gym and working out with a trainer as opposed to driving by the gym saying you're going to go tomorrow, which is what most of us really do with Kegel exercises. The most definitive treatments for stress urinary incontinence are surgeries. So the surgical techniques, we've had lots of them over the years. Bulking techniques were popular years ago, and that's where we actually inject something like collagen. There's other things like Durasphere beads and things like that where we inject in the wall of the urethra. It makes it pucker up a little tighter. We still use that in certain cases, but it's very specific. There are some older procedures that some of you may have had, or your mothers may have had, or you have had friends that have had. You might recognize the Birch or MMK. Those are older procedures. They were done open, where we kind of anchored the bladder up to the pubic bone. The most common surgeries now, and what is considered the gold standard for stress urinary incontinence now, is something called the mid-urethral sling. So the mid-urethral sling, basically what it does is it supports the tissue that you've lost support for. So, you know, as I see that tissue bounce down on exam, or, you know, when you cough and it bounces down, what we do is put a hammock under the urethra so that when you cough, laugh, sneeze, that door can't bounce back down. We don't squish the urethra. We don't tighten it. We don't do anything like that. We put something very loosely underneath of it, but once that scars into position, that back door can't slide open. According to the literature, 87% of people are completely dry 15 years after having that done. So it does tend to hold up. You can recur, but most people don't. And that's why it's the gold standard, because we want to fix somebody and we want you to stay fixed, if that makes any sense. Okay, what would you expect if you were to choose surgery? First of all, it's an outpatient procedure. Everybody goes home the same day. It involves a little incision about this big under the mid-urethra, and then in some cases no other incisions, because we do have a single incision sling now that is very close to being able to be done in the office. But some of the other ones involve 2 puncture wounds either in the groin or right above the pubic bone, but those are so small they don't even need stitches. You do wake up in the recovery room with a catheter in your bladder, but that's just so I can make sure you can urinate before you go home. Once you're awake enough, we put some fluid in your bladder, we take the catheter out. As long as you can urinate it back out, you go home with the catheter. About 99% of all of my patients will go home without a catheter. But we want to make sure, because I don't want anybody to be in the emergency room that night just because they couldn't urinate. Pretty much covered that, I guess. Okay, so that's stress urinary incontinence. So we're going to change tracks now. Okay, so just the thing to remember about stress urinary incontinence, it's a physical pressure on the bladder. It always happens with activity. Your options are Kegel exercises, pelvic floor rehab, or surgery. Okay, so now we're going to talk about something else. We're going to talk about overactive bladder. Now, urge urinary incontinence is under the umbrella of overactive bladder. So overactive bladder includes everything from frequency, urgency, getting up at night, going, not being able to get to the bathroom in time, which would be urge urinary incontinence, and it has to do with the behavior of the bladder. So basically the bladder is going back to its native reflex and it wants to urinate all by itself. Any of you who have children or grandchildren, you know you don't have to do anything to get them to urinate. You don't have to pinch their toes or tickle them. The bladder fills and empties all by itself. It's a reflex we were all born with. If we let it do its own thing, it will. We learn to control that when we potty train, but as we get older, that reflex reactivates. And the primary reason it does is because our bladder gets weak and our pelvic floor muscles weaken, and then we no longer are able to control those sensations. It's extremely common. 33 million Americans have, now this is overactive bladder, not necessarily urge urinary incontinence, but it falls under that umbrella. So 33 million Americans have overactive bladder. 40% of adult women have some symptoms of overactive bladder, whether it's going frequently, getting up at night, or whether it's not getting to the bathroom in time. It costs our society $76 billion a year. Now let me put that in perspective for you, because numbers to me don't mean anything unless I can link it to something. That is the net value of Bill Gates. It is also more than the net value of the NFL, Major League Baseball, National League Hockey, and the Basketball League combined. And that's what we spend on overactive bladder, between diapers, doctor visits, pads, protective things for the bed, changing our clothes 2 and 3 times a day. Here's the thing that I think overactive bladder causes more distress in people's life than stress urinary incontinence, partly because it's so much more out of our control. Most of us can kind of tell when we're about to sneeze or cough, and maybe we don't do that very often, but overactive bladder comes without any warning at all. And I've had many, many patients tell me very embarrassing stories about being in Publix. You get there, and they had just this accident, and they literally had to turn around and go back home. Or they're on their way to the doctor's office, and a lot of people come an hour away and they have to stop 3 times before they can get here in an hour drive. So it interferes with the way people live their lives. So it's a major reason for people to become shut-ins, because they just don't want to deal with it anymore. They don't want to go out, they don't want to have to take extra pads, they don't want to take a change of clothes. It decreases physical activity. I have a lot of people who don't go to the gym because of it, or don't exercise because of it. And then that starts a spiral of other things. Then your health isn't as good, and then your blood pressure is not as good, and your diabetes is not as good, and then you're less mobile. And we know that as you start becoming less conditioned, other problems arise, and then your quality of life goes down. Paged 3 times while I'm on call. I am a mess the next day. So I have no idea how people get up 3 and 4 times a night and function the next day. Decreased self-esteem. It's not very flattering, to have an embarrassing situation. It also affects, for example, we live in a warm climate. We have beautiful weather and beaches, but a pad doesn't look very good under a bathing suit. So I know a lot of people will avoid going out on a boat or going, sitting around at someone's pool for a pool party just because they don't want to be put in that situation. People also don't travel. I've had many patients tell me that they just can't endure the plane ride, the time that they are not allowed access to the bathroom because of their overactive bladder. So that's pretty much sort of what I already said. Frequency, urgency, going to the bathroom at night, and then urge urinary incontinence, which is where you actually lose urine in the process. Okay, so again, the physiology of this is not an external pressure on the bladder, it's the bladder itself contracting. So it's the behavior of the bladder that is going on there. What kind of things cause that? A weak bladder plus a weak pelvic floor is what the primary thing that causes it, and the things that lead to it are a lot of the same things as stress incontinence, but for different reasons. But pregnancy, vaginal delivery, hysterectomy, obesity, neurologic diseases, so people who've had a stroke, people who have Parkinson's, people who have MS, they are going to have worsening problems because the nerves are now involved, and so the bladder is going to go back to its reflex because the brain cannot communicate with the bladder the way that it used to. Anxiety. I have people who are very type A and very anxious are more likely to have overactive bladder. Caffeine is a big one. I drink like 3 Red Bulls a day, so I have to admit I have an overactive bladder, but I will admit it's self-induced. It's my fault, okay? It's not my bladder's fault. If you drink 3 Red Bulls, you're going to go a lot. Nicotine, chocolate's a big trigger. Urinary tract infections. Anybody who has a urinary tract infection, you know you have to go more often, but then the bladder's now irritated. Now you've triggered the overactive bladder symptoms again. Okay, the AUA, which is the American Urologic Association, has guidelines on how we're supposed to treat overactive bladder, and there's 3 levels. So first-line therapy is pelvic floor strengthening along with behavior modification. Second-line therapy are medications, and third-line therapies are more advanced things. I'm going to go over those in a little bit more detail. So pelvic floor strengthening with behavior. The behavioral things are like managing constipation, avoiding caffeine, Making sure you urinate before you go out to the store, and make sure you urinate, before you leave the restaurant. Timed voiding, watching how much you have. Don't have a whole bunch of fluids before you go to bed. These kinds of things. Doing voiding diaries. I have a lot of people do voiding diaries to see how much urine they're making at night, because there's a difference between the production of urine and the control of the bladder. And we all make more urine at night as we get older for several reasons. One, we make less antidiuretic hormone in the brain, which is a hormone that tells the kidneys to slow down. We're sleeping, so it would concentrate the urine. So the kidneys are just going on like they are during the day. Second thing is, even if you don't get swelling in your ankles, as we get older, we do collect more fluid in our tissues, and then when we lay down and all our tissue is the same level as our heart, that gets reabsorbed, and your kidneys are just doing what they do. They see more fluid and they have to get rid of it. So I'll tell you a trick that I tell my patients. It's kind of an easy way to figure out how much urine you're making at night. If you have a scale, weigh yourself before you go to bed, then weigh yourself in the morning after your first morning urination. The only weight you lost was the urine that you made during the night. 16 ounces weighs a pound. So if you're losing 2 or 3 pounds at night, then you're going to have to get up 4 and 5 times because you're making a lot of urine. If you're only losing a half a pound, you should be able to sleep through the night. That's just kind of a quick, dirty way of figuring that out. Okay, so the pelvic floor strengthening. You can do Kegel exercises on your own, or you can do pelvic floor rehab, which I said helps stress incontinence. That's the only thing that helps stress incontinence and urge urinary incontinence is pelvic floor strengthening. But pelvic floor rehab works very, very well for overactive bladder. The second line therapies that the AUA recommends are medications. These are all the commercials that you see on TV where the lady's following her bladder around and she knows where every bathroom is. When I got out of training, we only had 2 medicines available to us: oxybutynin, which is ditropan, and Detrol, and some of you may be familiar with those. So I tried one. If that didn't work, we tried the other, and we were done. We didn't have guidelines back then. We didn't have a lot of medicines to choose from. We're now very blessed that we have a laundry list of things that we can help people with. And as far as the medications go, there are about 12 or 13 that are FDA approved. They do work very well. The trick is finding one that the insurance company will pay for and that you have minimal side effects from. Most of them have very minimal side effects these days, so we can usually find something. Oh, the primary side effects of most of the overactive bladder medicines are constipation and dry mouth, but those are of the anticholinergics, which are the Detrol, Ditropan, Sanctura, Enablex, Vesicare, Toviaz, if any of those names are familiar. There's a newer agent out which blocks a completely different receptor, and it's called Mirbetriq, which does not cause those side effects. So if you've ever been on a medicine and it caused those side effects, we do have newer medicines that do not. Our recommendations, or at least my recommendations when somebody comes into the office, I tell them to do one of 3 things. My best recommendation is to do steps 1 and 2 together. Do pelvic floor conditioning along with some lifestyle changes and medicine. And the reason I recommend doing both is that we're working at the problem from 2 different directions and we get results faster that way. And let's face it, we are all in a microwave world. We want everything fixed yesterday. Even though this problem's been going on for 3 years, they want it fixed right away. So the quicker I can get results for patients, the happier they are. That doesn't work for everybody. Some people feel very strongly about not taking a medicine. That's great. Do pelvic floor rehab. Work with your own natural tissues and make them stronger. That will help. Some people logistically can't get to the office. That's fine too. Choose the medicine. But whatever you choose, you have to give it time. I tell people that this is a process that we're going to work together over a couple of months to make improvement. For example, if I put you on a medicine, I'm going to see you back in 4 weeks, and at that time we'll decide whether to increase the dose, change the dose, add something to it, or go on to the next step. There are third-line therapies that are approved by the FDA, and there are 3 of them. The first one is called InterStim, which is kind of like a pacemaker for the bladder in that it has a battery and a lead. But the way that it works is it stimulates the nerve that goes to the bladder. And if it works, then we implant it. So most people are familiar with people who have a pacemaker and a lead that goes to the heart. The difference is that the battery is in your buttocks cheek and it goes down to the S3 nerve, which is the nerve that goes to the bowel and the bladder. We always do a test in the office to see if it's going to work because we never can predict who it's going to work for, but it works for 2/3 of people. If it's a successful test, then we implant the full thing in the operating room. If it's not a successful test, then we go on to other things. The second one is Botox, Everybody's familiar with Botox, that you can inject it in the face and get rid of wrinkles. Well, we now can inject it into the bladder as well. It's been FDA approved for several years now. Now, the way that that works is it partially paralyzes the bladder. So that will give you more time to get to the bathroom, will give you larger bladder capacity. The pros and cons of it are it's not permanent, just like Botox that you inject into your face, it wears off. It does last at an average of 6 to 12 months. Most of my patients go closer to 12, except for the patients who have really severe symptoms. But insurance will pay for it as long as it's been 3 months. The other side of it is that I always counsel patients that if we do Botox, you have to be willing to take the risk that you might not be able to urinate afterwards, because we're trying to paralyze the bladder partially, but we can never predict exactly how far down that scale we go, and sometimes people's residuals will go up and they have to catheterize temporarily. That happens rarely, but I always have to counsel people that that may happen. And then there's an office-based procedure called percutaneous tibial nerve stimulation. It kind of uses the same science as InterStim in that it's stimulating a nerve, working at it from the nerve, but what we do is we access the tibial nerve, which is down here by the ankle, for 30 minutes once a week for 12 weeks in the office. This is just kind of a picture of the InterStim battery. It is about the size of a pocket watch, and it's very thin. It's about that size. So even on thin patients, I can get it under the tissue there where you can't see it or feel it. You will go off at the airport, so you'll have a card that says you have an implantable device, but nobody will be able to see it. And most people can't even feel it. The only way I can find it is the scar. And then Botox, I kind of already covered this, so I'll skip those slides, and percutaneous tibial nerve stimulation. Okay, so now I want to go on to the problem that I told you I think is probably the most under-recognized and undertreated voiding dysfunction in women. And it has to do, I've given you a clue, it has to do with the flow of your urine. I have women that come in that tell me that their urine just drips out, that the woman in the stall next to them sounds like a racehorse and theirs just kind of trickles and they don't know why. This is very, very common. So we're going to talk about it. So if you have slow flow, difficulty starting urination, feeling like you don't empty your bladder completely, if you have to strain to get started, or it takes it a few minutes to get started, or it starts and stops, or like I said, if the woman next to you sounds like a racehorse and you don't, then you might have one of these problems. So let's talk about the anatomy here. We have 3 structures that we're talking about. We've got the bladder that stores the urine, we have the bladder neck, and we have the sphincter. I think of the bladder neck and the sphincter as a double-layered door. They're both contracted. As all of us are sitting here right now, our sphincters are contracted, our bladder neck is closed, and our bladder is relaxed. That is in the resting state. The only part of urination that we control is the sphincter, and it's a relaxation. So when we want to go to urinate, we relax the sphincter. So we relax the sphincter. That tells the bladder neck to dilate into a funnel shape. Then the bladder contracts and urine flows through a funnel. So that's normal urination. If your flow is slow, if you feel like you can't empty, if it's trickling, any of those type things, there's only 3 possible explanations of what could be happening. One is that the bladder is not squeezing. The bladder is a muscle. It wears out just like everything else, and people have weak bladders. 2, the door's not opening, which means these muscles are in spasm, and that's called pelvic floor dysfunction. Or 3, something's in the way. Now men, the few men that we have in here, we always blame the prostate in you guys, but the rest of us in here don't have a prostate. So the only way we would obstruct our urethra is if our bladder's falling out to the point where we have a scrotum. Okay, people, if your bladder's falling down a little bit but it's not bothering you, you're not kinking your urethra. So if you have slow flow, it's one of the other 2 things. And the problem that I mentioned, that I said is the most under-recognized and undertreated, is pelvic floor dysfunction, which is the door not opening. And think about it this way, these are muscles and they're contracted all day long. So if you have a couple of muscles and they're contracted all day long, the only time they get to relax is the times you go into the bathroom. They can go into spasm. Then you go into the bathroom and you tell them to relax and they don't, or they partially open. Then your bladder is trying to squeeze against a straw, and that will cause difficulty getting started, slow flow, etc. And also, pelvic floor dysfunction causes and worsens overactive bladder, because now your bladder is working really hard to get through a door that's not opening, and it behaves just like a prostate in men. So if a man comes in, he's getting up at night, he's going frequently, he's going urgently, I know it's the prostate. It's the prostate in them. We don't think of that in women, but it could be pelvic floor dysfunction. So how do we treat that? Well, I just explained all that. So here are the things that cause it, first of all. Delay in urination is a big one. We call it nurse's bladder or teacher's bladder or anybody who's gone long periods of time without urination. When you do that, when you get urges to go to the bathroom, you tighten up your sphincter. That sends a signal to the spinal cord, which sends another signal to the bladder telling it to be quiet. We all know that happens driving down the highway and you have to go and there's not a bathroom nearby. But when you do that, you actually teach your body to contract the sphincter every time you need to urinate. And then you go into the bathroom and you can't. So delaying urination chronically is not a good thing. Hovering over the toilet is my biggest pet peeve. And women don't want to sit on the toilet. But here's the thing. The only part of urination we control is the sphincter, and it's a relaxation, okay? You cannot contract and relax muscles at the same time. Try it. I mean, try and contract your calf and relax your thigh. You're not going to be able to do it. Our tendency is to either tighten up or to relax, okay? So if you're hovering, you've got thighs that are contracted, your abdominal muscles are contracted, you're trying to balance yourself, and then you're trying to relax your sphincter at the same time. Trust me, it doesn't work. So I tell people, if you're a hoverer, feather the nest and sit, or pee at home. Straining to urinate is the same thing. If you're straining any muscles, then you're going to have difficulty effectively relaxing your sphincter. So don't do that. Relax, run water, sit, take your time. Men are in there all day long. I don't know why we can't take an extra 5 minutes in there. Stress and anxiety. Anything that increases muscle tension in our body can increase muscle tension of the sphincter in that area and cause pelvic floor dysfunction. I see it a lot in people who do a lot of core training, so like yoga instructors and Pilates instructors, and Lainey, this might be you, because she does a lot of yoga. When you tighten your core a lot, then you can get a hypertonic pelvic floor. Forced potty training is another one. That's not something that would have affected you, but it could have affected your grandchildren. So again, the treatment is we focus on what the problem is. Okay, since the problem has to do with the bladder neck and the sphincter being in spasm, that's what we focus on. In the old days, we used to stretch or dilate women's urethras. Some of you may have had that done, or maybe you know people that have that done. That's an old-fashioned way to treat the problem, and I personally don't like to do it unless it's the only way we can fix the problem, because it hurts. And it can cause scar tissue, and it can cause urinary tract infections and other things. So I like to do a kinder, gentler method and use medications. I have to use two, though, because the bladder neck is made of smooth muscle and the sphincter is made of skeletal muscle. So they're different structures and they have different receptors and they respond to signals from the body differently. For the bladder neck, I use a medicine called Flomax, which was actually invented for men who are obstructed by their prostate. And I always tell people that because even today, if you read about it, you Google it, or you pull out the package insert, it's going to talk about men and the prostate, and it's going to say do not use in women. That's because it was approved for men and it was never studied in women, but we use it in women all the time. We actually use Flomax in people who are passing kidney stones too, because we know it will dilate ureters. For the sphincter, I have to use a muscle relaxant. The one that I think works the best is a very, very low dose of Valium. Just 2 milligrams before you go to bed is enough to break the spasm in the sphincter without making you sleepy, sluggish, or tired during the day. Now, I can't use Valium if somebody's on another nerve pill. So if someone's on Xanax or Ativan or something like that, then we skip the Valium. But I use those two together, and if that's the problem, within 2 to 4 weeks, the problem will be better. That's pelvic floor dysfunction. The other problem can be that the bladder is weak. Okay, the bladder does wear out. So you can have what we call a hypotonic or an atonic bladder. Hypotonic meaning it squeezes but weakly. Atonic meaning it doesn't have any squeeze at all. This happens with aging. It happens with a lot of neurologic diseases, stroke, multiple sclerosis, Parkinson's disease. Anybody who has any back problems or spinal cord compression, it can affect the bladder's function, or chronically overstretching the bladder. It will not work. And the reason for that is the way that a muscle works. A muscle band is like this long if it's contracted and this long if it's stretched. It's made of fibers that are sliding against each other, okay? On those fibers, they have something called actin and myosin, which are these little arms that, depending on what position in, it either allows the muscle to stretch, or when they flip, it causes the muscle fibers to slide against each other. But if you overstretch a muscle, the arms are no longer able to touch each other, and then they lose their ability to contract. A real common scenario is people have a hard time urinating first thing in the morning. They'll say they get up and it's kind of slow. They don't feel like they empty. They get up, go get a cup of coffee, come back, urinate, and then they're able to do it. It's because they've partially emptied their bladder, they let the muscle reset, and then they can come back and urinate again. So that's why chronically overstretching your bladder can do that. Okay, so the two things that we can, there's only two things we can do for someone who has a weak, who doesn't empty their bladder or has a weak bladder. There's one medication that sometimes can be helpful, and it's called Botanicol. It intensifies the squeeze of any contraction the muscle has. So if it has a little bit of a squeeze, we can make it more intense. I have lots of patients that I've helped strengthen their bladder over time. Usually takes weeks to months for that to happen, but every person I've ever put on Botanicol, I've been able to get off Botanicol in that time frame. If Botanicol doesn't work, then InterStem can also work. I mentioned InterStem earlier because it worked for overactive bladder. It also works for underactive bladder. So if you're on either end of the spectrum, InterStem can be an option. And that may seem a little counterintuitive, but the truth is those are two sides of the same coin, because a weak bladder is an overactive bladder, but if it is so weak it can't empty itself, then it's a bladder that doesn't contract. So it's really sort of the same problem. That's why InterStem can work there. Okay, that's pretty much all I have, except for questions. And I know I've thrown a lot of information at you and you feel like you were trying to drink from a fire hose, but yes, ma'am.
I have IC.
Mm-hmm.
And I've had it, the last time I was diagnosed, it was 2003, I've been on medication.
Uh-huh.
Is there a way it can be cured?
There's no cure for interstitial cystitis, but there's no cure for me having green eyes either. So I hate to tell people it's not curable because it makes it sound like a terminal disease. It is a treatable condition. Interstitial cystitis is an inflammatory condition that primarily affects the bladder, whose primary symptoms are frequency, urgency, and pelvic pain with sterile urine. So a lot of IC patients, and I'm sure you've probably been treated with antibiotics multiple times before you ever got the diagnosis, because it's a very common thing. And most IC patients have seen 7 physicians before they're ever diagnosed with interstitial cystitis, because they're treated for the common things and not for interstitial cystitis. IC is treatable, but it is, it's a frustrating problem to have, and it's a frustrating problem to treat because no one thing works for everybody. Have you been on the ICA's website?
I've been a member of the IC club.
Okay.
And there's several million people that belong to it. So
Yes.
It's really common.
Yes. It is more common than people think. Actually, it's 1 in 5 women have interstitial cystitis. 1 in 5 women have recurrent urinary tract infections. That's pretty much the same, and they're not mutually exclusive. You know, you can have a foot in both camps, which really makes it complicated because we always have to make sure that it's not a urinary tract infection that's causing your flare. Medication, go ahead.
One thing that I did notice is that the treatment for one is just the opposite of what you need for the other. In other words, they'll tell you if you have like a urinary tract infection to drink cranberry juice.
Right, and you can't if you have IC.
It'll inflame it up.
Correct. Yes. I always encourage people to go to the site because this is one of the, most doctors don't like people to go to Google, and get a few minutes of information, but interstitial cystitis is different because it's such a heterogeneous disease. If everyone here had IC, you would all have different triggers, you would all have different things that make it better, you would all have different things that make it worse. So the more research you do on it, the more you can guide me in helping you. Because what works for you may not work for the person I saw right before you or the person I'm going to see after you. Medications are one of the cornerstones to try and, because the main problem with interstitial cystitis is the lining of the bladder is destroyed and the bladder can't heal itself. So it's your own urine that irritates the bladder. It's like having a diaper rash in your bladder all of the time. So we try to reform that lining with Elmeron. Elmeron, Vistaril, and Elavil are the 3 cornerstones because they attack the 3 problems. One's trying to reform the lining while the other one is trying to prevent the release of histamine, which is chewing up the lining, and then the other one is trying to calm down the nerves. You can stretch the bladder. That's a hydrodistension. You may have had that done before. For the most part, we try to treat the symptoms. For example, I have a lot of IC patients who have InterStim because of the frequency and urgency. And there are several studies that show that InterStim can reduce the need for pain medicine. So it does help the pain part, even though that's not what it's indicated for. It calms down the bladder, but a secondary response is that the pain can get better. That's a really long conversation, but I'm happy to have it with you, and maybe we can talk a little bit more one-on-one after everything is over, just because that's such a complicated topic. Anyone else have any other questions? I either totally confused you or answered all of your questions. Anybody have a good joke to tell? All right, well, I'm here. I'm going to stay here. Oh, I forgot. Oh, yes, yes.
You talked about the rehab. Is that just like exercises?
Well, pelvic floor, there's sort of two. Kegel exercises is the primitive exercise you can do on your own. Pelvic floor rehab is a more formalized thing where we help you strengthen your pelvic floor. So you work one-on-one with a nurse. We have a machine that we can connect you to with a vaginal probe so that we can help stimulate the proper muscles, which are up inside. And then you can do the exercises while we measure the strength of your contraction, the duration that you can hold the contraction. We can get you a home stimulator so that you can do these things at home. The average person goes for 8 sessions, and that's usually all anybody needs, and then that combined with the home stimulator, you can kind of maintain things at home. Sometimes people's pelvic floors are so weak they need maybe 2 rounds of it, but most people can get away with 8. But that's, yeah, it's kind of like physical therapy for the pelvis, but the muscles are inside, so it's definitely one-on-one in a private room. It's not like a yoga class. Any other questions? Yes, ma'am.
The books.
Yes. That's what I was just going to tell you. And I have a surprise for you because I talked the hospital into giving these to you guys for free. So anybody that's here gets one for free. If you want me to sign it, I'll be happy to do so. I doubt I'm really going to be famous anytime soon, and it's not ever going to be worth money, but I will be happy to sign it for you. But everybody that came here today does get one for free. And that is courtesy of Bay Medical Center. Okay? So yes, I have them. You can come get them. I'll be happy to sign them. And then any other questions that pop up, I'm here. Thank you all for coming. I know it's a stretch for you guys to come out on what today's Thursday at 5 o'clock with the traffic that we had to deal with. And that it's dark outside now. So, hey, hi.
You were the first urologist I saw